physician, eating disorders are psychiatric illnesses, but they have significant medical complications. So it's a must to make sure that there's a physician who's treating the patient. We talked about psychiatric comorbidities. Dr. Garcia mentioned that. So it's all, so in many cases, it's important also to have a psychiatric nurse practitioner or psychiatrist who can assess for depression, anxiety, OCD, self-harm, other psychiatric coexisting conditions. Eating disorders are not about food, but management of food is very important. And I think Chris nicely discussed the importance of managing the food. I remember many, many years ago, I had a very bright outpatient who, she was a Harvard student and she was in outpatient therapy, very underweight, anorexic patient. So after searching other treaters, she ended up with me and she said, you know what, the previous person I was with, clinician I was with, she kept saying, you need to learn to emote. And she said, what I need to do is eat. And that was really her first step to recovery. She did need to eat. She also needed to learn to emote because she was very constricted, very guarded, really didn't have labels for feelings, some of the things that you talked about, very much comfortable with intellectualizing. So both were important, but I think the part really, the first job starts with managing the symptoms. And with anorexia nervosa, that is about weight restoration in a gradual way, dealing with anxieties, but getting to a point that someone is weight restored. We have a lot of patients who bargain about that. They say, I'll eat, but I don't want to gain weight. They're not going to recover. Or they bargain about, well, can I reach just to 90% ideal body weight? And there is no recovery. Actually, they would have to maintain that weight. They need to continue to have some kind of eating disorder symptoms, which means then constant preoccupation with food and weight. And then again, that overvaluation of body and body image, as Shannon talked about. Your sense of self-worth very much gets connected to what you look like. So with bulimic patients, we want them to help them to use coping skills to stop the behaviors, the binging and purging. It's very hard to sit with individuals who are undernourished, underweight, engaging in significant behaviors, symptomatic behaviors, and want to do psychotherapy. They just are not there cognitively. You've got to get them to a point that initially they stop the behaviors before you start finding out how did they get there? How did they develop an eating disorder? What is it doing for them? Obviously it's doing something for them, right? Otherwise they wouldn't be engaging in these kinds of behaviors. And a lot of our patients say, it's not that I chose to develop an eating disorder. And I think, Peter, you very nicely talked about different factors that get into development of an eating disorder. And I think you should write a book. You summarized it so nicely, all the really insights for parents, would be a contribution to the field. So that's also important. And then, eventually you do want to address psychological aspects of the eating disorder. What is it serving? What is the function for the individual? And recovery comes when you push them towards life. When they start doing life, that's when they let go of the eating disorder. As long as they're terrified of doing life, they're going to hold on to that eating disorder. It's serving a function. They need it. When they don't need it, they're going to let go of it very gradually. So, as treatment centers, we try to provide them with tools to let go of the eating disorder and get to life. And there are different levels of care. I think, outpatient therapy, but also, if that's not sufficient, then there are centers like here, we provide intensive outpatient programs, which is a 3-hour program. We have 6.5-hour program during the day, which lunch is served and snacks are served, and that's really exposure. It's not just that we want to feed them. We want them to practice eating in a safe setting where they get anxious, there's staff that can support them. You know, you have residential programs for individuals who need 24/7 kind of support and treatment. And many issues come up. And inpatient medical, Dr. Garcia mentioned, there are patients who need to start with stabilizing medically. They may start with us and want to get into our system. The first, what we ask them to do is to have labs and EKG done, and some of them we end up sending to actually emergency room because their heart rate is too low and they need a medical stay initially. So there are different levels of care to take care of different levels of severity with this eating disorder. There are times that patients call and they bargain for less when they need more. Sometimes they ask for more when they need less. So that's the task of really doing thorough assessment and figuring out what is the best approach, what is the best way we can help someone. Family is important, support systems are important, educating families. There is still stigma about eating disorders, and I think some families try to not disclose it to their family support systems or neighbors or friends that they have, and that really isolates them and they suffer in silence. We have family support, multi-family support group at CEDC, and it's amazing when they start talking how, you know, the first time they take a risk and they tell a neighbor, and all of a sudden the neighbor says, oh, actually my niece also had an eating disorder. Or they tell a friend, and that friend says, you know, actually, you know, my daughter struggled. So eating disorders are very prevalent, but they are, I'll finish by saying they are treatable, full recovery is possible, and access to care is important. That's why we want to really support legislators like Kelly Ayotte, who are behind Anna Weston Act or other legislations regarding to parity, to give patients the access to care that they need to have. They can recover if you just need the adequate treatment for them. Thanks again for coming and making it a really good panel, and we'll leave, we have a question and answer period that Monica is going to moderate.
We're going to open it up to questions and answers from you. Tina is going to be walking with a cordless mic, so if you can just let me know just by raising your hand so I can direct Tina to the individual, and you are welcome to ask any of these wonderful panel members any question that you have for them. So who has a question? Oh, right over there. Somebody's got to get it started.
Hi, my name is Pam, and I am a parent of 2 children with an eating disorder, and I myself have had an eating disorder most of my life. And even when it started, binge eating disorder wasn't even considered an eating disorder. So that was kind of clever, trying to go and get help and say, no, I don't throw up, I just eat. So my question is there any research out there that shows with binge eating, I did have gastric bypass, that was my solution, which solved the problem to a certain degree, but absolutely I can still binge, but not as much as before. So is there any research out there that shows someone with eating disorder and how gastric bypass helps or hinders or, thank you.
So we're very glad that binge eating disorder became a diagnostic entity by itself in DSM-5. That's the Bible of Psychiatry and Diagnosis. So binge eating disorder is when someone engages in binge eating but doesn't use any compensatory behavior to make up for the eating episode, so they end up gaining weight. So, can I talk? Should I try? Okay. So, you know, gastric bypass. I'll talk loud. Okay. So, gastric bypass, we've got many patients who
have had gastric bypass, and the problem is if they haven't dealt with the eating disorder, the behaviors are still there. So they end up coming to get treatment. We have them in our IOP program in Cambridge, sometimes partial hospital programs. And I think as a result of that, now some insurance companies require, before giving someone permission to do gastric bypass, they want them to be in assessment and individual therapy for 6 months prior to doing that. Because gastric bypass is not the solution by itself. I think they're going to see more research coming now that it's a separate diagnostic category. So right now, I don't think we have good research.
I'd like to add to that. So as a dietitian, I also treat.
Hang on. Doing it a different way. Hands up again.
Is this thing on?
No.
This Okay, why don't you try that now?
Hello. Okay. So a lot of times dietitians and therapists are a little bit different in that I think our caseload is much higher than, say, a therapist caseload. And so eating disorders is not the only work that I do. And in some of my training for weight management, they have addressed, there are some kind of certificates of training for adult weight management. They've addressed gastric bypass surgery. There are multiple kinds of surgery, like there's a lap band surgery, there's a gastric sleeve, and then there's a Roux-en-Y procedure, which is the one that most people have. And the Roux-en-Y procedure is the one that seems to, of all of those procedures, cut out a little bit of the actual physical hunger mechanism, and we don't know exactly why, or I've never heard somebody say exactly, what the mechanism is, but it tends to be more successful. However, again, if you haven't treated the eating disorder, it's the coping skill of choice, or the default coping skill if people don't have other coping skills. And so that's why it could still be prevalent. Thank you.
From a medication standpoint, actually binge eating disorder is the one that's coming forward. So lisdexamfetamine was approved in February 2014 for binge eating disorder. But you can hear from the title, lisdexamfetamine, the mechanism of action is by appetite suppression. But interestingly, topiramate, which is an anti-seizure medication as well, I would have to say back in my days in training, we actually would put patients on topiramate who were doing the psychiatric assessments for the gastric bypass surgeries. And one of the reasons we were doing it was because it would suppress appetite. And we would hope to sort of suppress that as well as kind of calm some of their urges to eat. And so those are the two medications that are showing some promise. And it is, it has gotten FDA approval for that purpose.
Other questions?
Hi, my name's Jessie, and that's my mom. I'm so proud. I have a question for Shannon. I was wondering, how did it look for you when you started separating from behaviors, moving forward from recovery, and coming to a place where you were trying to figure out what you cared about again, and what kinds of places did you put yourself so that you knew you would be able to be making positive choices and making social circles outside of your eating disorder, and also just finding out who Shannon was. What are some things that you tried to do?
The first thing I did was move across the country. That's out of the question. But yeah, when I graduated school, I just kind of moved across the country from my family because I just knew that in that environment I was not going to get better. I'm not advocating for that, but it was just for me. I needed to get out of that environment because my family was not willing to do the work. It sounds like your mom is, so kudos, mom. But it's so funny that you mentioned that because I forgot that that's part of the process is that you have to remember what you like again. because I do remember I was like super into, I went to health coaching school, and I was like super into my studies and like learning everything about building a business, and like I just like dove into that and made that my focus, and I was not a fun person, and it took me a really long time to get comfortable having fun again. Like it used to make me ill to be around people enjoying themselves, because I was like, what is this? I don't know what this is. I'm so uncomfortable. I cannot be around joy. And it was, I think it's like an integration process of really realizing that like you can feel that and it's okay. Like it's okay to be happy. Like nothing's bad is gonna happen. Nobody's gonna judge you for being happy, or if they do, it's not really your problem. Like that's their thing to figure out. And just experimenting with different things. Some of the things that I used to like I used to love reading women's magazines, like Woman's Day and Family Circle. I was like an old lady from the age of 12. I had like a binder of cutouts about organization, OCD. So realizing I liked other things, like I recently got into powerlifting, which totally just changed the way that I view my body, because now it's like relating to food in my body. Like I know what the muscles are, and I know what I'm working out, and like just building that strength. Like that's a cool new thing that I never would have thought of doing before, and I never would have been able to do before, because it does require you to eat. Yeah, small detail. But yeah, just experiment with different things and see what works for you now, because you do change in the recovery process. Who you were before is not who you are afterwards, and that doesn't make who you were before bad or who you are now bad. It's just different. And so figuring out, it took me a while to meet people who were like kind of on my wavelength, and I knew, like my friend Jason that I talked about, I met him through like a raw food community. And so I just started looking at meetup groups about raw food, thinking like maybe there would be more Jasons in Florida. I met people, and I did meet more people like him, and that just kind of expanded my social circle and allowed me to be around people who were thinking on that same level of being loving, being compassionate, and it wasn't just like gossip, like a lot of the world is people who were more insightful and wanted to build like really deep, serious friendships.
Other questions?
I'm sorry. Okay, now I speak as an educator. I teach in an elementary school for 30 years, and I have seen incredible changes in food in the elementary schools. And now we've gone to the point with the wellness program where no one is allowed to bring in any cupcakes, and the lunches, no, you're not allowed to do anything that involves what they would call bad foods. And in fact, even, I'm a music teacher, so even when we have a cast party, we used to have ice cream, and now we're not allowed to have any of that. And as someone who's lived in this eating disorder world, myself, I find that like really scary, that that's the direction that it seems like a lot of public schools are going, where they take out machines, and they take out this, and they take out that, and so it's pretty much all or nothing. So what do you think is the recommendation? What's the right way for elementary schools or schools in general?
Okay. So with the epidemic of obesity in our country, and with I think First Lady putting emphasis on exercise or healthy eating and exercise, there has been a lot of pressure on schools to go in the direction of healthy food. What we know with eating disorders, many develop their eating disorders once they go on a benign weight loss program. So I think we have to be very careful what we're doing and how much emphasis we're putting on weight. In Massachusetts, there was an initiative about BMI, sending BMI reports to home, and that created a lot of problem. Kids who were fine with their bodies, parents who were fine with their kids' bodies, all of a sudden they were told, your kid needs to lose weight. So I think we have to be very careful with the message of weight loss. Not everybody who goes on a weight loss program and loses weight develops an eating disorder. But there are many individuals, vulnerable individuals, whose weight loss leads to development of an eating disorder. So I'm very cautious about that message.
I don't know if there's a right answer, but it is very complicated, and I know that Michelle Obama's really concentrated effort on managing an obesity epidemic has been helpful in some ways, and to understand that there are many, many medical problems and diseases related with obesity, whether it's like diabetes or sleep apnea or heart disease or anything, and so they're really trying to keep the population safe and healthy. I think that, unfortunately, this is just my own opinion, but that eating disorders are almost the collateral damage of this as a kind of an outreach effort, and they are really trying to cut expenses and costs. I mean, the medical care for the obese population for whether it's managing heart disease, diabetes, or whatever, is terribly expensive. And I almost feel like the eating disorders are kind of like the calculated risk of, at the, kind of the risk outweighs, the benefits outweigh the risk of having it. And unfortunately, we're kind of seeing that. I think that through the Anna Weston Act, we might be able to have more education outreach and people to be aware of this and to help people to understand that there aren't things that are good or bad, or that we're not defined by the look of our body or what people define as beauty or whatever, but we're not there yet, and so that's why I think we're eventually getting there. From a separate food service perspective, food allergies are now sometimes very severe. I can only postulate that, like, maybe there are some children who are born so premature and are in such a sterile environment that maybe they just can't tolerate things, but they can develop anaphylaxis if somebody just brings in kind of the cupcake with walnuts, and so they just can't have that anymore, and so we have to keep the school environment safe. And so there's like kind of a twofold, no outside food, I think it can be a safe thing, and at the same time, does it have to be exclusively healthy food for an age, like a part of the population that is just burning so many calories that they just need anything, and that, having Gatorade in the, vending machine could be okay, or that, like kind of that they can kind of get away with a lot of calories, and that way it doesn't create good and bad. And so there isn't a specific, I don't think, answer but I do think that they're trying to manage the overall risks. And unfortunately, I think that, and like that, at least we know more about it now than we did 15 years ago when I got started. But that it's just, we're not all the way there yet, and I think we just have to tolerate where we are and do the best we can to do things like this to be aware of it. Sorry to be so wordy about it, but I feel very strongly about that.
I would just add on this, that's not working. On the subject of good and bad foods, I always tell people, Shakespeare said it, so I can't take credit. Nothing is good or bad. The thinking makes it so. It makes me sound really smart. But the food isn't inherently good or bad. Like food, when we talk about calories, it's kilocalories or joules of energy. It's how much energy is in a piece of food. So it's not inherently good or bad that something has a high caloric density versus a low caloric density. And it's like, I think we put a lot of emphasis on what's good and bad, and it's, as someone who is conscious about health, like I don't like that there's like a lot of pizza and french fries. When I went to school, it was all like pizza and french fries for lunch. I wouldn't personally say that that's like the best idea, but teaching kids to have a healthy relationship with food and like to listen to their body about what feels good when they eat it. Rather than, because sometimes it feels really great to eat a burger or really great to eat a slice of pizza, and sometimes it feels really great to eat a salad. So instead of making those foods good or bad, learning how to listen to your body instead of letting an outside source dictate what you should or shouldn't eat.
Do we have other questions for the panelists? Going once? Right over here.
Hi, my name is Suzanne, and as a parent, How do you suggest speaking to someone that is a parent of a child that you are suspecting may have an eating disorder without making the parent look at you like, how dare you, or what do you know?
Well, just speaking as one of the amateurs on the panel, not a professional, have had that discussion with a coworker and took the approach of just sort of asking how life was going with the daughter, and got them talking, and they raised up issues which to me were more warning signs. And so it was sort of quietly doing a little detective work. And then they had some awareness of the recovery journey my daughter and I are on. And so I said, well, that kind of reminds me of, don't want to worry you, but as a friend, I do want to just point out the similarities, and then just sort of leave it like that. In this case, I had a strong enough pre-existing relationship with this person that the eyebrows went up, and there was oh thank you, and an awkward. And about a week later, they showed up in my office to chat a little bit more. They're very private, so I'm not sure what happened, but she asked me a lot of questions about, well, how do you check into this more? And so, it's kind of like, the old joke that a guy should never ask a woman when she's due. Never ask a parent if their kid has an eating disorder. To sort of ease into that and do a little detective work.
Do we have other questions? Okay, at this point then.
Sorry. Always cutting me off. I have a question for Shannon. How did you know when you switched from being like mostly recovered to recovered?
Ooh. I don't think there was like a cognizant realization until after it had been, when you have those moments you're like, that's different. Like, I feel like it just became so normal that when I reflected on it, I was like, wow, so something changed at some point. And I don't think I could define a point when I was like, oh, that's when like I hit recovery. Because even when I think about it now, I'm like, was it 2010 or was it 2011? But like somewhere in there, things just started to shift. And I would say like every day I'm just learning more and progressing more. And if I look at where I was a month ago or a year ago, it's different than today. So I don't think there was like a day that I knew that like everything was gonna be okay. It was just somewhere along the lines I had kind of developed that like everything's gonna be okay, fine, learning, every day is a new day.
I didn't want to cut you off again. Are there other questions?
You could also always ask anybody, probably, I'm assuming on this panel afterwards, if you wanted to not ask something in public.
Absolutely. So at this point then, I want